Hi, my name is Stephanie Chuang, and I was diagnosed with cancer when I was 31 years old. And like so many of you out there, or like many of the people you know, I was completely overwhelmed, freaked out, honestly, because I thought, am I going to die? I think that's a pretty common and human thing to think when you've been diagnosed with cancer. And I was really thankful to learn that there was a standard of care treatment in chemotherapy that seemed to have a pretty good impact on the cancer in DLBCL. I underwent dose-adjusted R-EPOCH, a little bit different from the usual R-CHOP for a lot of the people out there. And I remember my doctor telling me, look, Stephanie, if you can hit 2 years after treatment is done and the cancer is gone still, you're still in remission, that's a really good sign. It's great news that I was able to get through treatment and get into remission. But that wait was really hard. Lots of anxiety and scanxiety, as it's known. And look, I was able to hit the 2 years. And in fact, most recently, I celebrated my 5 years. But so many people cannot say that. And that's where the problem is. There's a really great need for more options in treatment if that first treatment fails you or fails your loved one. And when the cancer comes back, or if it never responded, that's relapsed refractory cancer. And that's what we're talking about today is, what are the treatments out there? What are the options? What should you know to be able to ask your doctor about in terms of the research that's going on out there? And look, there's good news there. There's a lot of different things happening in clinical trials, whether it's new drugs or new combinations, new tactics, and a lot of immunotherapy, using your own immune system to fight the cancer. And that's what today's conversation is about. I'm really excited to be able to bring together conversations with 2 top DLBCL specialists, and hopefully this will shed some light for you, especially during what is a very difficult time. And so I'd like to introduce our doctors. Dr. Josh Brody leads the Lymphoma Immunotherapy Program at Mount Sinai's Tisch Cancer Institute. Dr. Lorenzo Falchi is an oncologist at Memorial Sloan Kettering Cancer Center with special research focus on immunotherapies for B-cell non-Hodgkin lymphoma. And to kick off, there's a lot of new information and updates coming out of the biggest meeting of top blood cancer and disease doctors and researchers. It's called ASH, or the American Society of Hematology, which just took place. So first, I want to ask Dr. Brody, before we jump into the meat of this discussion, to talk about all these updates as we go into 2023, is a lot of people wonder, I did, certainly, when I was diagnosed, why me? What did I do to get this? And you were mentioning that this is something you hear a lot from your patients as well.
In the front line, in the very beginning, when patients are getting diagnosed, is a lot of questions just sort of coming out of a place of fear, very natural and understandable, which is, how did I get this? What did I do? As though someone wants to like blame themselves for this. I guess it's natural, but that's our first thing, is to go and say, there's nothing you did. You got this for the same reason that people get hit by lightning. Nothing that they did. You got this because of, primarily for most patients, because of one cause and one cause only, bad luck. That's why you got this. And then we say, in context, it could have been worse luck, because there are worse things you could even have. And then of course the questions are, what can I eat to make this get better? What vitamins can I take? And the answer is, you should eat healthy and be healthy. Being healthy is not just about eating, it's about physical activity and exercise, because we have a ton of data that physical activity and living healthy improves outcomes for cancers, for lymphomas, but we don't micromanage and have a specific, oh, you need these blueberries, this green tea, this antioxidant. Healthy eating, healthy living is critical, but the type, exactly the details, probably not critical.
Absolutely. And what can be critical is how much we as patients and caregivers or care partners know to make sure that we're getting the best care. So that's a great segue into this conversation. And I want to set the stage. So really, essentially, the standard of care has been R-CHOP as a first line, the first go-to strategy for people, an aggressive chemotherapy. But if that doesn't work for the patient, then there's that gap. There's a need of understanding what can we go to. And very basically, there's been this big focus on immunotherapy, and we've heard lots about CAR T-cell therapy, and that's been approved in DLBCL. The forward focus right now, and what was really exciting at this big meeting we're talking about, is something called bispecific antibodies, and that's really had a lot of progress in research too.
We were already lucky in lymphoma to have more progress than before. In the last couple of years, I would say the rate of progress has only increased. And the unifying theme there of things that are being invented in labs, by companies, in academia, if there's a unifying theme, it's immunotherapy, using our patients' immune systems to kill their own cancer. And this sounds a bit, back in the day, back 10 years ago, people thought this was a bunch of hocus pocus. We're going to use your immune system, use your body to fight this problem. But now it is a real, measurable, making people live instead of die thing. And especially the last couple of years, the progress in DLBCL immunotherapy has been unprecedented. And the most obvious examples are these things called CAR T cells, this science fiction-like immunotherapy that when I describe it to my patients, they say, but that's not a real thing. And I say, yeah, no, it's a real thing. And then we describe it, it's quite remarkable. And even this somewhat simpler type of immunotherapy that I think will actually have greater impact overall than CAR T cells, which is this class of medicines called bispecific antibodies, another immune therapy that gets your immune cells to kill cancer cells.
Okay, so to be clear, the idea of using your own immune cells to kill cancer is an idea that's been around, but really in the last few years is when we're really seeing the impact of this. And so before we dive into this big buzz of bispecifics, let's talk about CAR T for a moment, because as some people may or may not know, in the CAR T space, there have been 3 CAR Ts that have been approved in DLBCL, but they've been approved for third line of treatment. So again, the first treatment didn't work, the second treatment didn't work. Now we're going to the third one. And Dr. Brody, as you mentioned, CAR T has been able to put many patients into deep, complete remissions, which is what we're looking for. But the last year has shown that CAR T can be promising even earlier on. Is that right?
Some big trials showing remarkable benefit, CAR T cells as second-line therapy, not as the first therapy, but as second-line therapy. And so there they had to show that they were better than the standard in that place. That standard for second-line was aggressive chemo and autologous stem cell transplant, which is just very aggressive chemo. And it was focused, just as you're asking, on the highest risk people, only the folks with DLBCL who relapsed within the first 12 months. But that meant a lot of people relapsed in month 3, month 6. Some of them didn't even relapse at all. They got no response at all from the frontline R-CHOP chemotherapy. So on these highest risk patients, the benefit of CAR T cells compared to the old standard was remarkable. Many more of them staying in remission for months now. Now at this meeting, we have a 1.5-year follow-up of one of those trials here. Many more patients staying in remission. The old numbers with CAR T cells is we thought maybe we were curing 35-40% of patients just with those CAR T cells. So we'll see if those numbers kind of reproduce, or maybe might even be better now using them earlier, using them in the second line setting. So that is for the highest risk group of DLBCL patients that we're talking about.
Okay, that's really great. And so let's go into bispecific antibodies or bispecifics. Dr. Falchi, what is going on with them? Why are people so excited by them, and how do they work?
Well, bispecific antibodies are a real breakthrough class of medications for lymphoma and many hematologic malignancies, that is blood cancers. And what makes them a breakthrough is, on the one side, their novel technology, but on the other, the fact that that technology really translated into very impressive clinical results and real benefit for patients. And I like to refer to bispecific as the third big milestone in immunotherapy for lymphoma. The first being monospecific antibodies like rituximab that most people are familiar with in the field. The second being CAR T-cell therapy. And I think the third be bispecific antibodies.
Bispecific concept, it's actually very similar to the CAR T concept. The CAR T is it sounds so fancy, it's hard to believe. Literally, we take some immune cells out of your blood, takes a few hours, not too big of a deal. And we put a new gene in them, a gene that makes those T cells. The gene is called a CAR gene. So you put that CAR into the T cells, now we call them CAR T cells. But literally, we take the blood out, mail this to some place. It used to be Santa Monica, now there's a few places, and then they mail it back to you, and then you reinfuse those CAR T cells into the patient. The bispecific antibodies, very similar idea, just maybe a little simpler even. We don't actually have to take the T cells out to make them recognize lymphoma. We put in this thing called a bispecific antibody. Many folks have heard of rituximab, a regular antibody, binds to one protein on one cell. Bispecific antibody binds to two cells. So it binds to your lymphoma cell, binds to your T cell, bring them together. We sometimes say, one of my colleagues said this is like the Lady and the Tramp with the spaghetti in between them. And then at the very end of the spaghetti, in this case, is the kiss of death because the T cell kills the cancer cell. And that Lady and the Tramp image is a pretty good one. I think I have to credit Dr. Matthew Lunning for the Lady and the Tramp metaphor. But that kiss of death, these T cells are highly activated and able to kill that immune cell, kills that cancer cell quite effectively. And the punchline is, even in folks where the standard therapies didn't work, even where CAR T cells weren't working, it seems like more than a third of patients with these bispecific antibodies are getting complete remissions. And that's, again, the highest risk group of patients. So if in the worst case scenario, it seems like more than a third of them are getting complete remissions.
Okay, so let's break down what we should be looking for in terms of bispecifics. As we know that, these drugs are being developed in clinical trials, and there are different phases where they're bringing them to patients and seeing how patients do on them, studying dosages, and not just how effective they are in terms of how much more people can live without the disease, but how well. So what are the side effects? So let's dive into that. Which ones currently in clinical trials are expected to get approvals sooner?
So I think it emerged quite clearly that the two main actors in the world of bispecifics for patients with diffuse large B-cell lymphoma are epcoritamab and glofitamab. These drugs are both highly potent, very, very powerful. In fact, in experiments done before using them in patients, it was shown that their potency is exactly the same.
Because they have so many patients now, got to parse out the patients with high risk, super high risk, and all the different risk factors. One example is, as we said, CAR T is a very promising thing. But, a year or two ago, if CAR T failed, the options were not great. So now we have these groups of patients where the CAR T has failed. It's about a third of the patients in both the epcoritamab and the glofitamab trials had already had CAR T. The CAR T didn't work because it's not a guarantee. It's great, but it's not a guarantee. And the epcoritamab or glofitamab, here at this meeting, we're talking more about the epcoritamab in that parsing of the data, and it was still giving complete remissions in more than a third of patients. So even when the best things weren't working, this new thing, bispecifics, epcoritamab in that case, still highly effective. Glofitamab so far has some advantage in that all the recipes for them have been written as time limited. You get 12 cycles and you're done. 9 months of therapy and then you get a break. The epcoritamab studies have been written so far to be continuous therapy as long as it's helping you and not hurting you. Whether we need to keep giving it for a long time, we don't really know, but at least it's a difference so far. And the other big obvious difference is that the epcoritamab, the way we get is different. It is a subcutaneous injection, so it's kind of quick, a little shot and you're done. You'd almost think you could just get it at home, but we haven't worked on that yet. And the glofitamab is an IV infusion still.
Okay, so again, we don't have any FDA-approved bispecifics in the DLBCL space yet. The hope is that maybe there will be approvals soon, sometime this year. And so this is information being based off of these, research studies. A very important topic, as mentioned before, is side effects. The quality of life. Okay, great. We can extend life by, X number of months, or someone's, in remission for this amount of time. But we also truly want to understand, are we going to be able to live well while on this treatment, or even once we get off of the treatment? So can you set the stage for what kind of side effects we've seen so far in the studies with bispecifics?
So we talked about all the promise. We do not want to oversell this. There are also side effects of these medicines. The most significant or maybe concerning side effect of all of these bispecifics, really all these immunotherapies, is the risk that we push your immune system too hard and you get a reaction as though you had an infection, but there is no infection. It's just that we push your immune system to react. And one version of that is a side effect we call CRS, cytokine release syndrome. And CRS can be significant, make you get a high fever, make you get low blood pressure. If you get a real bad version of this, you have to be in the hospital for observation and sometimes for treatment of that.
So rates and severity of CRS for bispecific antibodies appears to be, at least at this stage, quite substantially different compared to what we see with CAR T-cell, particularly axi-cell, which is one of the most utilized products for diffuse large B-cell lymphoma. In those studies, in the CAR T-cell studies, we're looking at double-digit % of higher grade CRS. And for that reason, most patients, particularly those who are a little bit more advanced age, need to be hospitalized for several days after receiving CAR T-cell. For bispecific antibodies, we're looking at a 24 to 48-hour hospitalization, and we're confident that in the future, as we gain more experience, there is a possibility that these drugs, who I would like to remind everyone, they're off-the-shelf products, so immediately accessible, can be given on a fully outpatient basis without having been admitted to the hospital.
And so to be clear, we're not saying that with, bispecifics being so promising and that if they are approved, that they'll erase the need for CAR T-cell therapy. But what we're talking about is there are details that are coming out in this research that will help doctors and patients and care partners determine the best treatment path for each individual. And some of those factors would include what is available, what is quicker to get, because sometimes time is going to be a big factor there. What are the side effects? Like we've talked about, how long would someone need to be monitored in the hospital or the clinic for side effects that are more severe, like CRS, the way you've both described? Is there anything else that you would consider in making the treatment decision about whether someone should go on a bispecific or CAR T?
On a logistical basis, CAR T-cell therapy is quite an involved therapy. It needs to be administered by specialized centers, and in the U.S. there's many such centers, but they're not everywhere. So it's important to know where these centers are, who can administer those therapies. Doctors have to be certified, centers have to be certified. It is not a therapy that everyone can give. They require hospitalization for the majority of patients. Some patients can receive CAR T-cell therapy on an outpatient basis, but for now, that's, I would say, a minority of patients. The majority will require hospitalization and monitoring, and even after discharge, oftentimes patients will be required to stay in the area where CAR T-cell therapy was administered for a period of time. And in the post-CAR T-cell therapy period, there's periodic monitoring where the doctors will want to look at blood counts and other blood work or scans, multiple times in the months ensuing CAR T-cell therapy. As far as bispecific antibodies are concerned, these are drugs that are administered either subcutaneously or intravenously, for the most part on an outpatient basis. And this is important because although none of these drugs are currently approved by the FDA, it is hoped that one or more of them will be approved in the near future because of such promising results. Therefore, it's important for us as academic clinicians and for our colleagues to become very familiar with these products. And I think really the point to make about these drugs is that they can be safely administered as an outpatient therapy, and their main side effect, which is cytokine release syndrome or CRS, is something that is to be expected in a certain percentage of patients, and we all will need to become familiar with it and how to manage it promptly. Management of CRS from bispecific antibodies has not been as quote-unquote complicated as it has been for CAR T-cell therapy, in the sense that drugs like acetaminophen, drugs like steroids, including prednisone or dexamethasone, which are drugs that we very commonly use and most patients are familiar with, are the mainstay of therapy for most cases of CRS related to bispecific antibodies. Only rarely patients treated with bispecific antibodies will need higher level of care that includes hospitalization and other drugs that are used to calm down a more severe CRS.
So the bispecifics right now, they're being studied both as single agents, meaning just the bispecifics alone, but also in combination with other treatments that are already being used. So we'll have to see how those turn out. But as we're also talking about different bispecifics, We know that they're being tested for later lines. Again, third option of treatment, fourth, fifth. And then typically what happens is the research tries to move them earlier.
The real future of that is not just how good are they alone, because we never really cured any cancers alone. We didn't cure some DLBCL patients with C. We cure them with RCHOP. Combinations is kind of the basis of oncology. So with these easier to use bispecifics, the next step is how we can combine them with some standard therapies, and that's already being done. We have some data about that here at the ASH annual meeting, and those response rates are extremely high. So, that is the future. And like we say, it's for now third-line patients where everything else has failed, but they are very quickly moving up into the second line. We have some data here at the meeting about second line, and even that we've already started studies bring them into the first line in combination with the standard therapy. So, it's a rate of progress. We're very lucky. The luckiest thing would be to have no cancer at all, but, if you had to have something, better to have something where the progress is being made this quickly.
As single agents, I think what we've seen is that now with longer follow-up for the studies, some of those individuals who had a very good response early on tend to maintain that response. And there is a suggestion that some of these patients may become long-term disease-free. In other words, being alive and well without evidence of disease at a relatively long follow-up time. We're all very cautious toward the word cure, but we certainly believe that there is a potential for these people not to have a recurrence.
Thank you, Dr. Falchi. One example is a study that was presented on patients who are eligible for transplant, but didn't do well after the transplant. And so they're studying epcoritamab or EPCO for these patients. What was the main takeaway there?
There's one abstract here about epcoritamab plus this aggressive, we say platinum-based chemotherapy, two versions that are DHACs or RDHAC. Not very friendly names. They should soften up some of those letters, but DHAC or DHACs are aggressive platinum-based chemotherapies that are usually, a plan B, plan A, something like R-CHOP. And if it doesn't work, plan B for younger, healthier patients would be to get platinum chemotherapy, RDHACs, other similar ones. RICE is another similar one there. They're all just platinum chemotherapies. And if it works well, then go on to autologous stem cell transplant. And stem cell transplant maybe sound a little elegant because stem cells are involved, but really it mostly involves tough chemotherapy. Folks are hospitalized for a while and out of work for a while. So adding epcoritamab to that second-line platinum chemotherapy, just trying to get the complete remission rates up high enough that the transplant would work better. And yet, even in that trial, although patients were sort of intended to go on to the stem cell transplant, some patients that got a complete remission with just the epcoritamab plus platinum chemo never did go on to the transplant and are still in remission up at beyond a year now. We cannot yet say if those patients are cured. They may be. A little more follow-up would hopefully confirm that. But yeah, the epcoritamab is clearly making that chemotherapy work much better.
We participated into that study, and the early results on a relatively small number of patients appear very promising. For those patients who were able to complete the program, their chance of response was 100%. And the majority of them were complete response, meaning the lymphoma really disappeared. Obviously, we don't know what's going to happen in the long term, but it's certainly a very, very good start.
And that sounds so promising. One thing we'd like to highlight here is that research relies so heavily on the data, on the numbers, and that's for a very good reason. But putting the numbers and the percentages into context is also really important here. Some of the research that's presented at the conference that just happened is called PRO, or patient-reported outcomes. And very simply, it's something I hope there's a lot more of because it gives that context. There was one report, again, these are coming from patients on quality of life, those kinds of issues. There was one report for epcoritamab where the number was 61% of interviewed patients reported positive impact on their daily activities after being on the bispecific. Around 40% reported a positive impact on physical, emotional, and or social functioning. And 80% of patients reported being, quote, very satisfied or satisfied with treatment. Now, again, want to stress, this was a limited sample size. It was in this clinical trial of more than 100 patients. But I do want to ask you, Dr. Brody, why is this information so important to study?
Yeah, patient-reported outcomes are critical because the other version of that kind of data is so unfulfilling. It is just these kind of graphs of adverse effect frequencies, but that does not tell the story, because if someone had a grade 3 toxicity for 20 minutes or for 2 years, it just adds up as the same on the graph. It's just they had a grade 3 toxicity. But a human experience is that 20 minutes, not so bad. 2 years, I would rather have a grade 3 toxicity of many types for a day than have a grade 1 toxicity for a year. Grade 1 toxicity for a year, you maybe can't go to work or can't work well. So that's why patient-reported outcomes, for especially I think for these immunotherapies, especially for bispecifics. Again, this main side effect I alluded to for bispecifics, the most common one is this cytokine release syndrome. It can be a bad thing. It can be a serious thing. You can end up in the ICU from it. But the nice thing about it is people kind of either have it or they don't. Again, maybe 20% of people have a bad version of that immune overactivation, CRS, and those that do mostly last for about a day or two, and then they pretty much don't ever have it again. So, that is a grade 3 toxicity, but for most people it is 2 days, God willing, out of their life. So, the fact that the way we normally report these in meetings, at abstracts, and publications, something falls short, because the patient's perspective is that a 2-day side effect is not the same as a 2-year side effect. It's totally neglected in the way we present the data. That's why the patient-reported outcomes are critical, and why the numbers, I think, are very promising for these types of immunotherapies.
Absolutely. Asking patients for their perspectives is so important. And again, something I hope will trend in that upward direction. As we close this discussion out today, what is the general takeaway for DLBCL patients and for their loved ones watching this as we go deeper into 2023?
So my general takeaway about bispecifics is one of great excitement. It is my line of research, because I truly believe that these are breakthrough therapies that offer hope to a substantial proportion of individuals, of people that would otherwise have very little outlook, suffer from a recurrent lymphoma that can be unforgiving. And so opening avenues of hope for patients with diffuse large B-cell lymphoma that recurs after 1 or more lines of therapy, which is very, very challenging to deal with, is something that I think we're all excited about. I'm personally just looking forward every day to what's coming next and how many more people we can cure, hopefully more and more each day.
Thank you so much, Dr. Falchi, and thank you, Dr. Brody. So excited by the things that were discussed. Obviously, we couldn't cover everything out there that's happening. We'll definitely be putting on more conversations for people who are wondering about more comprehensively what's available out there. And again, the important questions of, okay, that research is great, the numbers are promising, but how soon are we going to probably see this, at our hospital or at our clinic? Will it be accessible? What are the side effects? Will I be able to live life while I'm on this treatment? And so boiling all of that into a really understandable conversation that's coming up for sure on the patient story. But I hope that some of this was really helpful for you watching today. And just remember that with everything that's happening right now, it is so important to be up to speed on the latest that's happening, so that you can ask those questions of your doctor and make sure that you and or your loved one is getting the best care possible. And again, remember, you are not alone. For the patient's story, I'm Stephanie Chuang. Have a great one.